This exciting poster spotlight session 18, Advancing Our Understanding of Invasive Lobular Carcinoma, Potential to Develop Personalized Therapeutic Strategies. So we will kick off with the first 4 abstracts. These are abstracts more on the translational side. And to review these for us, we have Dr. Christos Sotirou, who will discuss these 4 exciting abstracts. And his title is Translational Topics in Lobular Breast Cancer. Over the next 15 minutes, he will do his discussion. We'll then have our 4 presenters come up on the podium. We'll do a nice Q&A, so feel free to ask all your burning questions. And we'll do the same thing with the next set of abstracts, the remaining 5 abstracts with Dr. Mukhtar. Thank you.
All right. Thank you. Thank you very much for the introduction. All right. This is my disclosures. All right. So we're talking about lobular breast cancer. I'm sure that everyone here knows what is lobular breast cancer. We know that about 10 to 15% of breast cancer patients have this histotype. You know that there are differences in terms of clinical pathology and biology. For instance, in clinical pathological characteristics, we have those patients are older, they have larger tumor size, they tend to recur late, and they have this bizarre pattern of relapsing, and also they respond for the classical lobular CDS to chemotherapy. In terms of biology, we know that the loss of gadolinium is the key element in lobular breast cancer. The majority are, of course, ER positive, HER negative, and they have this glioproliferative globulin A based on the PAM50 classification, grade 1, 2. They have low immune infiltration. There are some specific mutations. For instance, there's enrichment of course, CD1 mutation, but also in PIK3CA, AKTP10, and RBB2 mutations. They overexpress AR. When we have, for instance, in triple negative lobular breast cancer, they are the ones that actually are classifying as the luminal adjuvant receptor because of overexpression of AR, and there's other growth factors in them that are also expressed. Now, when Steffi actually said this questionnaire to ask what would be the priority research questions regarding lobular breast cancers in clinicians to laboratory-based researchers as well to patients advocates, what came out as important questions to address is to better understand the tumor microenvironment of lobular breast cancer, one of the top priority research questions. And so what we know in terms of TILs in breast cancer, you know, everybody here knows that in triple negative breast cancer, ER negative, we have more TILs, and when more you have TILs, you have a better outcome. In ER positive tumors, they are in general less proliferative as compared to triple negative breast cancer. We have lower count of TILs, and for those patients ER positive that have a little bit higher TILs, the prognosis is not that great as for TNBC. There are some differences. Now the degrees of TILs in ER positive tumors may explained by the high expression of aromatase in breast tissue, which leads to higher estradiol estrogens in the milieu of the tumor microenvironment, which increase expression of FOXP3 and down regulates gadolinium. That we need to have gadolinium in order to keep those TILs, those lymphocytes within the tumor, and globally you have this more immunosuppressive TME. Also in terms of TILs, this is what when Christine was in the lab, we found that in lobular tumors have lower number of TILs, if you count the TILs, as compared to ductal carcinomas. And curiously, for those lobulars that have a little bit higher TILs as compared to the ones that do not have at all, their prognosis is worse. And this was replicated from other groups, for instance, the group from Curie, as shown here on the right of this slide. Let me see if I can have the pointer here. And so the question here is why? Why immune infiltration in ER positive and lobular breast cancer is associated with bad prognosis? And there is any other determinants of immunosuppressive TME in lobular cancer beyond these TIL accounts. And this is what I'm going to discuss here. We have 4 very interesting abstracts. The questions that they tried to address for the first two abstracts is what are the intrinsic and extrinsic characteristics of lobular breast cancer compared to ductal carcinomas, and what the difference in terms of tumor microenvironment between lobulars and versus ductals. And for the two other abstracts, now we're focusing within the lobulars. Are any differences within the lobulars that associated with a different prognostication, and etc. I will come that to more detail. So the first abstract from Lise Mangiante is interested in that she works in Christina Curie's lab in Stanford, and I'm sure that all know is inter-cluster classification developed by Christine. And here she showed that there are at least 8 different integrative clusters among the 4 that all express ER, and there are 4 of those integrative clusters that they do very poorly, and they tend to occur later on, up to 20 years after diagnosis, as compared to the other 4 ER-positive inter-cluster patients that they have a classical recurrence rate. So the question that they try to address here is that, is there any differences in terms of genomics and transcriptomics in lobular cancer, how lobulars fit with that classification, and is there any difference in terms of tumor microenvironment for those patients? So here the study design summarizes, they leverage 400 primary lobular tumors, combining genomics, transcriptomics, and also they have done some single-stage spatial resolve transcriptomics based on looking for 54 primary lobular cancers. And so what they found is that when you map the lobulars, which are shown here in dark blue, to that classification, they showed that the majority of the lobular cancers, they have quiet genomes. They behave like the ER typical tumors, so the ones that are gentle in general, and as compared, for instance, to the ER high-risk tumors that are down here. So despite, though, that they showed that the lobular tumors have a quiet genome, they are gentle, they're not very disturbed in terms of their genome, well, the recurrence rate is even worse as compared to the ductal carcinomas. You see here, for instance, that, and this is more pronounced in the ER-typical subgroups. You see here that these 4 ER-typical groups of patients, being lobular, they have tend to occur and have a worse outcome and late outcome as compared to the ductals. So it means that, having the same genomic makeup, so why those tumors still have a poor outcome? So maybe this has to do with the tumor microenvironment. This is the next question that they try to address, whether there is differences in terms of tumor microenvironment lobes compared to ductals, and they looked for that classification. This is an interesting paper that came up in Cell 3-4 years ago that showed that there are at least 4 distinct tumor microenvironment patterns in all comers, actually, in several and different tumor types, that they call immune-enriched fibrotic, showing that those tumors, they have a lot of CAFs, as well they have signatures that shows that they have pro-tumor and anti-tumor infiltrates there. They have this immune-enriched non-fibrotic. It is actually the best tumor microenvironment in terms of outcome and response to immunotherapy. They shows that those microenvironments has cells that are anti-tumor. They include anti-tumor infiltrates as well as pro-tumor infiltrates, but less CAFs. Then we have the fibrotic microenvironment with a lot of CAFs and less adaptive response. And then we have the depleted microenvironment that actually they do not show any of those components except that they proliferate more than have this TME signature. So the investigators in that paper, they compared this classification, and they did found that in lobular cancers, they enrich with what they call immune-enriched and non-immune-enriched fibrotic, which means that there are more CAFs, there are more immunosuppressive microenvironment as compared to the ductal carcinomas. Also, they looked for differences in the single-cell level, differences in terms of communication, colocalization, how those tumor cells communicate with the stroma and fibroblasts, and they found that in lobular cancer you have have more of this type of communication and colocalization as compared to ductal carcinomas. So to summarize, what they show here is that being lobular and you do poorly, despite the fact that the genomes are gentle, quiet. They have more immune fibrotic microenvironment, more CAFs. They have a higher level of cell-to-cell communications. There are some questions here. They show that from that classification there are more CAFs, but there are several CAFs, and I will come to you later to that. And it would be interesting to know, what are the difference in terms of CAFs according to that classification to different intercluster subtypes. Is there any difference in terms of immune composition? And it would be very interesting to know, and I know this is an ongoing now study of the ligand receptor interactions between tumor cells, immune cells, and other type of cells in the tumor microenvironment. Now let's go now to the second abstract that is more focused on the CAFs story. And the question that they try to address is, does ICA inactivation loss in lobular cancer impact the tumor microenvironment that you're just losing ICA? And what is the CAF composition in lobular compared to ductals, and how these influence in interactions between immune cells? For that, this group from Curie, they did a tremendous work on characterizing CAF. This is a very interesting paper, a very important paper. Actually, they published many papers on characterizing the different subpopulation of those cancer-associated fibroblasts. And to summarize, because I don't have enough time to do that, there are two sorts of CAFs, two sorts of fibroblasts, the cancer-associated fibroblasts. What we call the ICAFs, that include detox ICAF, interleukin ICAF, interferon gamma ICAF, which are more immunopermissive. It's a good to be there. And we have the bad ICAFs that they call, that includes the ECM extracellular matrix MICAF and TGF-beta MICAF. There's a very, very immunosuppressive fibroblast in this microenvironment. So they, very simply, they just isolated those fibroblasts and they compare what is the composition of those fibroblasts in lobulars as compared to ductals. So here the numbers are small. Try to have the here it is. So the numbers are small, the 15 ductals and 6 lobulars. But you can see here from this graph here that when you are lobular, you are enriching with ICAFs, I would say the good CAFs, and you have less of the bad guys, MICAF, as you can see here. And they were able to validate that in larger cohort using immunohistochemistry, and also they validate by deconvoluting those signatures in DCGA and another series from Curie, having the RNA bulk. And you can see here clearly that here we see the ductals, here you see the lobulars, you see that there's degrees in terms of proportion of the detox ICAF. But however, I would like to highlight here, you still see here an increase of the guys, the TGF-beta and MICAFs. But the most interesting finding that I found in this study is that they demonstrated that losing CTU-H1 actually is associated with differences in terms of T-cell composition. So again, this is now the T-cell subpopulation for the ductals, for the lobulars, and you can clearly see here that in lobular carcinomas, you decrease the numbers of the CD8 TREM T resident memory cells, which are important, good T cells who have a good adapting immune response as compared to ductals. And they demonstrated that this is due to the loss of ICA. It also demonstrated, don't have time here to go in details, that those cells, not only you're losing, there are less, but they're less active in globulars as compared to ductals. So to summarize here, what they demonstrate is that the CAF composition in lobular cancer is different as compared to ductal carcinomas. They have more detox ICAF, they have less extracellular matrix MICAF, but there may be a higher proportion of the TGF-beta MICAF. They also demonstrate that you see less adaptive immune response, less CD8 TREM in globulars that may explain less unfavorable immune response in globulars as compared to ductals. So I have some questions and I have some clarification here that I didn't really realize, but just the question here is that still we know that they have less stills. We need to understand what are those stills that are okay, we know that there is less CD8 TRM, but there are many other T cells that Tregs and many others that we would like to know, and that may explain, this immune suppression microenvironment in lobulars that we don't see in dactyls. Now, the third abstract now is regarding the question, does glucocorticoid receptor activity impacts the tumor microenvironment in lobular breast cancers? So this is a question that this group of investigators, they had published previously that in lobular in vitro data, if you increase the GR, the glucocorticoid receptor, which is a nuclear receptor that is involved in cell stress, those cells diminish their proliferation. They proliferate less. So they went further, want to understand better these, and they performed some special transcriptomics analysis. Again, the numbers are not very high, and they demonstrated that in the expression level as well as the protein level, that when you overexpress, though the lobulars with high expression of a GR, they have a relative exclusion of CAFs, and they downregulate the MHC class II antigen presentation. Again, and less, more immunosuppression microenvironment in that population. And they did some single-cell in situ spatial transcriptomics, and they did find indeed that in GR-positive lobulars, they have less cancer cells, they have more normal cells, which goes together with low proliferation. And actually, I didn't show you here, but there are model A, and when we express on GR. And also, they also looked for the composition of the different fibroblasts, CAFs, and they did show also that when you express GR, you have less MyCAFs and have more iCAFs. So to summarize here, they demonstrate that when you express GR, you have less proliferation, you have less tumor content, you have more iCAFs, you have your decreased expression of MHC 1, 2, and you have some bad guys that again induce immunosuppression, so low proliferation, low immune. But the limitation here is that the numbers are very, very small, and they include all comers. Because you're going to see that in globulars, it's just not one, and even in the classical isotypes, there are more subtypes, and we didn't see survival data. But this is we might discuss later. I know the last abstract was actually from my lab. This is, I have this conflict for Matteo. The question here is that can we now achieve a more granular classification of lobular cancers based on TME and based on other spatial architecture? So what Matteo did, so he took 43 lobular cancers, and he ran the 10x genomics platform, and actually very nicely he combined the expression data from the spots that you get from that experiment, but also he combined with the homologies that annotations that we have in tissue, and also the co-occurrence between the different morphologies within the tumor. So by combining the expression and morphology, he came up with what he called the TMA-based ILC classification on 4 different subtypes with a different survival. I will show you here. Just to highlight that the majority in that cohort of lobulars were classic. So he found that there are at least 4 stable, because he could able to validate that in an external data set, stable lobular subclasses that he called normal stroma enriched, proliferative, metabolic, and metabolic immune enriched. So here, for instance, the normal stroma enriched are lobulars that contain more stroma, less tumor cells. In terms of the gene expression, more stroma-related pathways, of course, expression. In terms of the single-cell deconvolution, more CAFs, and particularly here MyCAF. But again, this is within the lobes, not between dactyls and lobulars. Proliferative, they have more tumor cells. They have a signatures that are associated with proliferation, and in terms of the single-cell deconvolution, there are more cycling cells. In metabolic, in terms of gene expression, more metabolic pathways, activation of the androgen receptor, and in terms of single-cell deconvolution, more endothelial cells, which maybe points towards more angiogenesis. And then we have the metabolic immune-rich subtype that he has here in terms of morphology, more adipocytes, co-occurrence between tumors and tumor cell adipocytes. In terms of gene expression, more metabolic and immune-related pathways. In terms of the cell deconvolution, more macrophages. I will come to that. So this is This is, again, what I demonstrate just to highlight here that in the metabolic immune enriched, the cells that we found there were more the innate immunity, so more neutrophils, more macrophages, and depleted to the adaptive immune response. Whereas in the proliferative, we see some adaptive immune response, some. Not that great. In terms now of survival, you see that the normal stroma enriched, they are the ones that have the better survival, everything the less good survival, and whether it's bad survival, as compared to the proliferative that they showed the worse survival as compared to the others. Now, he noticed that in this immune enriched, there was this colocalization between tumor cells and adipocytes. Then we went to see what's happening there. So this green here shows the area that we see tumor cells and adipocytes, and he figured out and he found that actually in that area we see a lot of macrophages, and particularly macrophages M2. And this is a nice paper from Steffi's group that he demonstrated that comparing the tumor microenvironment between ductal and lobular carcinomas, that lobular tumors have more macrophages as compared to ductals. And this is not due to the expansion of macrophages, but it's due to the less T cells, B cells in lobular microenvironment. And also they demonstrated that not only we have more macrophages disproportionately, but also there are the bad ones, the ones having the M2-M1 ratio. All right, so to summarize, we have these 4 different subtypes within the lobulars. The 2 of those shows high tumor content and more immune permissive. We have the 2 others that have more stroma and more immune suppressive microenvironment. But still, there are some questions that we have to address. For instance, why in the proliferative subtype, which we see some adaptive immune response, those patients that do badly. Where I think that because, intrinsic characteristics is important. When you have a high proliferative tumors, where probably the wins against the weak immune adaptive response. And the opposite, why in the gentle, I would say, in the normal stroma enriched subtype, we have better outcome despite that we have more immunosuppressive microenvironment. Again, low proliferation, probably there are cells that are less aggressive and they have a general better outcome despite the fact that you have very immunosuppressive phenotype. So to conclude, immune infiltration is associated with poor prognosis in ILC. What we learned from these studies is that we have clearly less effector T cells despite moderate proliferation. You have more Tregs, you have more bad calves, the TGF-MyCalf. You have more macrophages than bad macrophages. That all points to pro-tumor TME. And we have less CD8 TRM, which shows no long-term protection that may explain actually the later occurrences of those globular cancers. Now, why immune evasion? So it comes from the lobular tumors themselves because they have quiet genomes, they are low proliferative, and there is not enough neoantigen for an effective immune response, and this is due to the loss of CDH1. Now, protection therapies, there we have to target intrinsic characteristics, ER, androgen receptor, PI3K. There are studies now ongoing looking for those drugs. We have maybe to increase neoantigen release, and we have clearly to target innate immunity in stroma. This is something that we don't have to take. This is my vision. If we still validate that classification, you may think, for instance, to target not only tumor cells, but also their tumor microenvironment. For instance, metabolic enriched subtype, we might actually target macrophages, and there are drugs that you can target these macrophages. And in the normal stroma enriched, you should target bad fibroblasts, or include also some angiogenic drugs, metabolic androgen inhibitors, as well as targeting Tregs. And the proliferative maybe chemotherapy, maybe do something. And immunotherapy is open question for that particular subtype. With that, thank you very much for your attention.
Thank you. Could I request the 4 presenters to join us on the podium as well? Dr. Sotirou, if you can join as well. There are 4 microphones in the room, so please come up to the microphone for any questions that you might have for any of these presenters. You can also send your questions online using the QR code. Give them a moment. Thank you. Thank you very much.
Hi there, Wayne Stollard from the University of Pittsburgh. I have a question about the final poster that was presented that showed the 4 different ILC-TME subtypes. And I wondered if there was any evidence that you found of multiple subtypes within a given tumor. These are not necessarily distinct subtypes, but actually could be spatially segregated neighborhoods of different phenotypes.
Yeah, so we didn't. We didn't investigate it yet. What we saw, of course, it's always like a high level of heterogeneity in terms of pathways and like in terms of cell composition. So what I expect, of course, is to observe and to see this kind of heterogeneity. Yes. Mm-hmm.
Thanks.
I have a question about E-cadherin and in terms of what its role would be in terms of interaction with immune cells, and the other aspect is downstream, what's its interaction with beta-catenin and TCF1 in terms of what's important in lobular.
So the interaction, in fact, we investigated the ligand receptor interaction between E-cadherin and some potential receptor in human cells. And we found some heterotypic interaction with integrin alpha E, which is expressed at high level in CD8 T resident memory T cells. We didn't found any other kind of interaction between E-cadherin positive cancer cells and other immune cells. And we didn't investigate the downstream effect for immune cell. We know that integrin alpha E and E-cadherin interaction are involved in the immunological synapse. So yeah, this is main role, and so it is really important for cytotoxicity and for killing the tumor cells.
Thank you. Other questions? I was curious about a question. You know, it's very interesting to look at these spatial transcriptomics data and looking at these tumor intrinsic and extrinsic characteristics in lobular cancers and how they differentiate potentially from invasive ductal cancers. I was just curious, would we expect to see these differences in primary tumors distinct from metastatic tumors? And what have we learned about that? Or how would we think about these, you know, cancer-associated fibroblasts or these characterizations between primary and metastatic?
That's a very good point. So far, we investigated the primary untreated lobular tumors compared to the primary untreated ductal tumors. We do have 7 patients for which we have pairs between the untreated primary and the metastatic lesion. So it's going to be still pretty much descriptive, but we are hoping to see if some of the features that we find in the primary being different between the lobular and ductal and potentially related with a higher risk of dissemination is like changing or stable between the primary and the metastatic lesion. I think it's going to be hard to look at differences between the different organ sites, but we are hopeful to see if we have a signal that seems to be intrinsic of the tumor and that allows this interaction in the primary, and see if they also still express those receptors or those ligands also in the metastatic lesion, because that would mean that they are still potentially able to interact the same way with fibroblasts, especially this is what we find. So very curious to go to that step, but for now I don't really have the answer.
Yeah. Thank you for that effort. And maybe this is, you know, pushing that question a little further, just thinking about when we think about lobular cancers, we think about how with more and more treatments, we see this APOBEC signatures, we see this high tumor burden, and we look at these acquisition of acquired mutations, which make tumor environment interesting. We have approved immunotherapy for high tumor mutational burden, which certainly is interesting for our lobular patients with high tumor mutational burden. How do we think about this immune microenvironment with such a advanced metastatic phase. Do we think that that tumor environment that we're looking at right now with immune-rich characterization is what we would expect in that setting as well, or would we expect that to be different?
Can you just repeat your last question? I think I missed just a few words.
You know, how when we have the high tumor mutational burden, which might be something that might be attractive for IO checkpoint inhibition therapy, do we think that the tumor microenvironment in that setting, if you had to think about, I know we don't have that data, but if you had to think about how would that reflect in that setting?
Yeah, no, that's a very good point. This is also something that we find because in the first study for which we had the whole genome sequencing data, we actually had this in 3 different stages of progression. And from the primary to the metastatic setting, actually, the subgroup for which we find the most accumulation of alteration was actually in the typical risk, so in the lobular. So that's the one that are going to accumulate more burden across these 2 stages. And so from the perspective of the spatial data, we are wondering if we are going to be able to see changes because they are accumulating more aberrations, so maybe they're more prone to be seen by the immune environment. So we don't know exactly yet because one challenge is going to be once again the organ where we find the lesion because they can be prone to more or less infiltration. Another organization. So we are hopeful that maybe we are going to see that, especially if we have, since we have the single cell resolution, maybe going to deeper into the resolution of what is going on between one cell that seems to have certain aberration next to the immune cell can try to answer a little bit this question, but we are going to need to go very deep, I think, rather than like a global insight because we are going to have bias because of the organ.
Okay, thank you. Dr. Sotirou, any comments?
Oh, I mean, yeah, and actually we can actually interrogate that in our Aurora program. We have all these patients, and but it's complicated because you have these late occurrences, and probably there's dormancy or there's of lobulars when they wake up, but clearly they probably accumulate more and more alterations that it's probably very different from the primary.
Any other questions from the audience?
Right here.
Yes.
Kira Gustafson, patient advocate here with the Alamo Foundation. So with all the developments in immunotherapy, is there one specifically sensitive to lobular that's being studied for therapy, immunotherapy, and treatment?
So there is, are you asking for like a therapeutic agent that is specifically studied for lobular?
Specifically for lobular.
Yeah, and I'm not aware of any specific IO agent that is being studied specifically for lobular cancer. We utilize pembrolizumab, which has an approval, high tumor mutational burden, and we have some data in ER-positive patients from the ASCO TAPER study in that regard, specifically for ER-positive small group of patients, but nothing specific that we have studied only for lob cancer at this point.
Do you think that may be in the future?
I'm sure as we have more and more agents and we start thinking about this, we can look into this, but I don't think right now we have a way to distinguish the benefit between lobular and ductal by different IO agents at this point. But it's a great question. Thank you.
Okay. Thank you.
Thank you. That was an exciting discussion on the transcriptomic topics. Moving on to the clinical side, and we'll talk more about some clinical outcomes. We have Dr. Rita Mukhtar from the University of California, San Francisco, talking to us about advancing clinical outcomes. She'll be discussing abstracts 5 through 9.
Thank you so much to the organizers as well as to the authors for allowing me to discuss these posters. I'll be talking about 5 posters. The first one is about lobular carcinoma in situ. The second one is about an ILC-specific clinical prognostic tool. And the last 3 are actually preoperative systemic therapy trials in early-stage lobular or ER-positive HER2-negative breast cancer. Patients with early-stage lobular breast cancer face unique challenges. Because these tumors present at higher stages, yet tend to have lower molecular risk, there's a higher rate of discordance between this clinical risk and molecular risk, which can make treatment selection more challenging for these patients. Additionally, the pattern of recurrence is different in lobular, with more late recurrences in lobular compared to ductal cancer. There are persistent clinical concerns about potential relative tamoxifen resistance in lobular breast cancer. Additionally, a small portion of lobular breast cancer patients have tumors that are triple negative, HER2 positive, or pleomorphic. And we won't be talking about those today, but we will be talking about pleomorphic lobular carcinoma in situ in the first poster. So starting with the first poster. Classic lobular carcinoma in situ is actually a marker of elevated risk for future breast cancer development in either breast. And for class LCIS, the typical management is surveillance and risk reduction. However, there is a small subset of LCIS that is more aggressive with higher risk, and this is pleomorphic and florid LCIS, which represent around 5% of all LCIS. Pleomorphic and florid LCIS are characterized by nuclear atypia and abnormal architectural features, and there are small series in literature that show that there is a higher rate of missed invasive cancer associated with these lesions at the time of surgical excision, and treatment guidelines are lacking, in particular the role of therapies such as radiation. This led to the multi-LCIS study, where the authors attempted to address some of these unanswered questions by putting together a very large series from international sites, 23 centers that contributed data. So they accumulated 245 cases of either florid or pleomorphic LCIS and looked at treatment and outcomes for these patients. The results are shown here. For pleomorphic LCIS, the upgrade rate, or finding an associated DCIS or invasive cancer at surgical excision, was 32.5%. For florid LCIS, the upgrade rate was 13.6%. A subset of these patients had sentinel lymph node biopsy, and none of them had involved lymph nodes. Most of the patients were treated with lumpectomy, and 15% had radiation. The local recurrence rate for these patients was 14%. And the factors that were associated with having a local recurrence were positive margins and having multicentricity. Interestingly, radiation use was not associated with decreased risk of recurrence in this data set. So the takeaways for this paper is that for patients with pleomorphic or florid LCIS, surgical excision to negative margins is recommended, but there is no need to do a sentinel lymph node biopsy. And in this data set, there was no apparent benefit of radiation, but I think that we need more data because only a small proportion of patients actually had radiation in this data set. Next, we'll move on to invasive lobular carcinoma. This study demonstrates the creation of the first clinical prognostic tool for lobular breast cancer. And this came from the MD Anderson database, which contains data for over 4,000 patients with stage 1 to 3 lobular breast cancer treated between 1966 and 2021. The authors put together a multivariable predictive model that predicts overall survival and recurrence-free survival. Some of the predictive factors are highlighted here. As expected, a higher number of positive nodes and larger tumor size were both associated with worse overall survival and worse distant recurrence-free survival. Some additional interesting findings included the histologic subtype of ILC. So classic ILC was associated with better outcomes than non-classic ILC. Additionally, the presence of LCIS was also associated with outcomes. For patients who had ILC with associated LCIS, the outcomes were actually significantly improved compared to patients who had ILC without associated LCIS. Endocrine therapy was associated with improved outcome, but the tool does not allow us to discriminate whether one type of endocrine therapy is better than the other. The tool is actually available as a clinical calculator online and gives a 5-year and 10-year predicted overall survival and distant recurrence-free survival probability. This is an important step towards tailoring therapy for lobular breast cancer, and validation and external data sets, of course, will be needed. Right now, the tool is prognostic. We do need predictive tools because treatment selection is an unmet need for lobular breast cancer, and there is ongoing work further refining this model. The next 3 posters are prospective trials, window trials and neoadjuvant trials for lobular breast cancer or ER-positive, HER2-negative breast cancer. The endpoints are highlighted here, and I'd like to take a couple of minutes to just discuss these endpoints. So first, why should we conduct preoperative therapy trials in ILC? One potential benefit is that we may be able to improve an individual patient's outcome by giving a short window of treatment and assessing tumor response. We may be able to better select the next appropriate therapy. By giving neoadjuvant treatment for a longer duration, we may be able to downstage tumors and improve surgical outcomes, and this is especially important for lobular patients who present at higher stages and have more extensive surgery. Additionally, preoperative therapy trials can identify drugs that have efficacy signals, identifying candidates for testing in the adjuvant setting. But what do we know about the endpoints for lobular breast cancer? One of the commonly used endpoints for neoadjuvant endocrine therapy trials is the preoperative endocrine prognostic index, or PEPI. PEPI is calculated from the surgical specimen after 3 to 4 months of endocrine therapy. The components of PEPI are listed here: the pathologic tumor size, the number of nodal status, Ki-67, and ER status. By adding up these points, you can calculate a PEPI score, and PEPI 0 is associated with excellent long-term outcomes. You can also calculate a modified PEPI score by omitting the ER status. Ki-67 is a component of this PEPI score, but you can also look at early change in Ki-67. The patients who have tumors where the Ki-67 drops to less than 10% in as little as 2 weeks of treatment with endocrine therapy have a much higher likelihood of achieving PEPI 0 status if you continue the endocrine therapy, and this is independently associated with improved long-term outcomes. So both PEPI score and early decrease in Ki-67 are commonly used endpoints in neoadjuvant and window endocrine therapy trials. For patients who receive neoadjuvant chemotherapy, you can use the residual cancer burden. The residual cancer burden is a way of quantifying the amount of invasive disease that's left over in the breast and lymph nodes after neoadjuvant chemotherapy. RCB 0 means that there is no invasive tumor left in the breast or lymph nodes, and this is equivalent to pathologic complete response. RCB is a continuous score as well as categorical, and it does predict event-free survival after neoadjuvant chemotherapy. But how do these endpoints relate to lobular cancer? Some have raised concerns that many lobular cancers may already have a low baseline Ki-67, rendering early change in Ki-67 potentially less informative. Most of the trials validating these endpoints have very few lobular patients. The PEPI score includes both pathologic T category and N category, and we know that these tend to be higher in lobular patients, so how they relate to outcomes may be different. And a recent validation of RCB in lobular breast cancer patients treated with neoadjuvant chemotherapy showed that the RCB index is prognostic for lobular breast cancer, but the relationship with outcomes was nonlinear at lower RCB indices. So we need to keep these ideas in mind as we're evaluating the results from these 3 posters. The first poster is the Translational Breast Cancer Research Consortium 037. This is a multi-center randomized prospective trial for postmenopausal patients with early-stage lobular breast cancer. Patients were randomized to receive 3 to 4 weeks of either fulvestrant, anastrozole, or tamoxifen prior to undergoing surgical treatment. The primary outcome in this study was change in Ki-67 after 3 to 4 weeks of therapy. I'll point out the median baseline Ki-67 in each of the treatment groups here. And as you can see, the median Ki-67 at baseline in these early-stage lobular patients was above 10%. The results of TBCRC-037 are shown here. These are box plots showing the log scale change in Ki-67 before and after treatment. In all 3 treatment arms, Ki-67 did decrease after 3 to 4 weeks of treatment. When comparing the magnitude of decrease between the treatment arms, there was no statistically significant difference between the fulvestrant arm and the anastrozole arm, or between the anastrozole arm and the tamoxifen arm. But the magnitude of decrease in Ki-67 was significantly larger in the fulvestrant group compared to the tamoxifen group. So takeaways from TBCRC-037 include that this first prospective preoperative window trial in ILC shows feasibility of conducting multi-center trials in lobular breast cancer. Importantly, the majority of cases did have baseline Ki-67 greater than 10%. The clinical concerns about reduced efficacy of tamoxifen compared to AI were not reflected in the results of this particular trial. And the benefit of fulvestrant brings up the question of the role of new classes of oral SERDs for lobular breast cancer, and correlative studies are ongoing with the results awaited. The next poster is the PELOPS study. PELOPS is a randomized phase 2 window and neoadjuvant trial for patients with ER-positive, HER2-negative breast cancer and was enriched for patients with lobular breast cancer. In the first randomization, patients were randomized to 2 weeks of tamoxifen or letrozole, and in the second randomization, patients were randomized to letrozole with or without palbociclib. The endpoints for this trial included early change in Ki-67, residual cancer burden, as well as the modified PEPI score. Here we see results from the window phase of the trial looking at change in Ki-67. On the left is the invasive ductal carcinoma group, and on the right is the invasive lobular carcinoma group. In this trial, treatment with 2 weeks of letrozole resulted in greater reduction in Ki-67 than treatment with tamoxifen for both patients with ductal and lobular breast cancer. Looking at the results of the neoadjuvant phase, there was no difference in the proportion of patients who had mPEPI 0 or a difference in RCB index in patients who received AI alone versus AI with palbociclib. There were some very interesting findings from correlative studies from PLOPs. This is showing gene expression changes in cell cycle-related genes in patients who received tamoxifen, with ductal patients on the top and lobular patients on the bottom. We can see that in patients with invasive ductal carcinoma, treatment with just 2 weeks of tamoxifen induced changes in these cell cycle-related genes. However, for patients with lobular breast cancer, tamoxifen did not impact the expression of these cell cycle-related genes. In contrast, for patients who received letrozole, the gene expression was impacted for both patients with ductal and lobular breast cancer. PLOP showed us that conducting a prospective trial stratifying by histologic subtype is indeed feasible. And although the early change in Ki-67 did not appear to vary much by histology, the transcriptomic analyses showed differences in cell cycle signatures that were mediated by endocrine therapy between lobular and ductal cancer. While we need to know how these signatures relate to long-term and clinical outcomes, it suggests that early change in Ki-67 may not be telling the full picture in regards to how lobular breast cancer is being impacted by these treatments. The addition of palbociclib to the AI did not increase the rates of mPEPI 0 or PCR, but it would be interesting to see whether or not this was different by histologic subtype. And finally, the last poster is an androgen receptor inhibitor study. This was also a randomized phase 2 neoadjuvant study for patients with ER-positive, HER2-negative early-stage breast cancer. Patients were randomized to 4 months of treatment with fulvestrant alone or fulvestrant with enzalutamide, an androgen receptor inhibitor. Patients underwent a biopsy at 5 weeks so that early change in Ki-67 could be evaluated, and the primary endpoint was the proportion of patients who achieved mPEPI 0 status. The majority of patients in this study had ductal breast cancer, but there was a small group of patients with lobular breast cancer. Looking at the proportion of patients whose tumor Ki-67 dropped to less than 10% at 5 weeks shows us that there was no difference in the treatment groups, with around 40% of patients having a drop in Ki-67 in both arms. The proportion of patients who had mPEPI 0 status was 7.7% in the fulvestrant group and 24.2% in the fulvestrant plus enzalutamide group. This did not reach statistical significance. The authors then shared analyses looking at the factors associated with achieving mPEPI 0. And one of the very interesting findings from this study is that those with lobular histology had higher odds of achieving mPEPI 0 after receiving enzalutamide than those with ductal histology. Some other interesting findings related to enzalutamide inducing changes in gene expression that are associated with immune system activation, as well as protein expression analysis looking at differences by histology. Takeaways from this study: the addition of enzalutamide induced changes in the tumor immune microenvironment. mPEPI 0 status was more common in the enzalutamide group, but numbers may have been too small to see a statistical difference. There was an intriguing association between lobular histology and mPEPI 0 status with enzalutamide, but of course there were only 11 lobular patients, so we do need more information about factors that may have been associated with mPEPI 0 status, but it does certainly raise the question of a potential role for androgen receptor inhibition in lobular breast cancer. And the proteomic analysis further highlights differences between lobular and ductal breast cancer, supporting the need for lobular-specific studies. So in summary, these posters demonstrate that we do have great progress in studying lobular breast cancer with the creation of multi-center studies to build large cohorts of rare entities such as pleomorphic and florid LCIS. We saw the creation of the first ILC-specific online clinical prognostic calculator. And the window of treatment and neoadjuvant studies highlight some important findings, including the fact that tamoxifen can lead to early reduction in Ki-67 in postmenopausal women with lobular breast cancer, but a drop in Ki-67 and other endpoints may not reflect tumor response the same way in lobular breast cancer. Lobular cancer is indeed biologically distinct from ductal breast cancer, and we saw early evidence that androgen receptor inhibition may be an important area of further investigation. Thank you so much.
Can we have the 5 presenters for their abstracts join us at the podium? I would love to take any questions from the audience first. Yes, I see you there. Thank you.
Hi, Matt Sikora, Colorado. Dr. Jesselson, I wonder if you could maybe comment a little bit more on the gene expression changes. There were only a couple pathways on the poster. I wonder how broadly you did or didn't see cell cycle gene dysregulation. And I saw there were differences in some estrogen receptor signatures. Can you comment more on what was different in ILC and IDC?
Yeah, so some of this is still work in progress. But clearly we saw when we looked at all the different hallmark pathways of proliferation, so both mitosis, G0, G1, or E2F signatures, we clearly see that there's a significant difference overall in all patients in IDC with both tamoxifen or letrozole. But in the lobular breast cancers, we saw a difference with letrozole in proliferation. But we didn't see a difference in the decrease in proliferation markers that was consistent among the patients with lobular breast cancer. So overall, that was not significant. The other thing that we show in the poster is that when we look at the estrogen responsive genes, which are really the hallmark ones, are generated from mostly from MCF7 cell lines. So those are all ductal models. So when we look at that gene signature, we see that indeed letrozole, if we get in the letrozole-treated arm and tamoxifen-treated arm in the ductal models, we see that signature does go down. But in the lobular breast cancers, both with letrozole and tamoxifen, we don't see a decrease in that signature, suggesting that really the estrogen-related signature in lobular breast cancers is different, which is consistent with both your work and our work as well.
Great, thank you.
Hi, Christopher Bullis. I'm a medical oncologist from Sutter Roseville. So my question is really for the panel. It seems like invasive lobular carcinoma clinically presents with 2 distinct entities, either asymmetric density, spiculated mass, circular sometimes, but it's involving the TDLU. It's kind of a localized presentation. And it seems to co-opt the intralobular mesenchyme. And then there's these diffuse invasive lobulars that come out of nowhere and seem to be huge and involve multiple nodes and seem to co-opt the extra lobular mesenchyme. They seem to be 2 different entities. So I'm just curious if anybody on the panel has a comment, or where do you study these clinically, and are they different? I mean, they seem like they have different clinical outcomes, different clinical presentations. And we see this over and over clinically. So just curious to see if the panel has any comments. Or not.
Well, I'll just agree with you. I would say I completely agree, especially I think we have 2 surgeons here on the panel. I think this comes up a lot with surgical planning, where sometimes you get preoperative imaging and you go to the operating room and the tumor is 3 times the size as what the imaging indicated. And then the next operation, you decide you're going to take a larger piece and you find out that the tumor was exactly the same size as what the imaging indicated. So why this happens, I don't think that anybody understands, but there's definitely some tumor phenotypes that are mass-like, despite the fact that they're still lacking E-cadherin and have these single-file lines under the microscope, and some that are more diffuse. And definitely this is impacting the clinical management and the clinical outcomes, and I think we need to understand the difference between those two a lot better, and I don't understand it. I'm not sure if anyone else on the panel does.
Thank you. Thank you for the good question.
Thank you for your comments.
I have a question for the enzalutamide poster. For those patients that achieve a proliferation response, did you measure a adenosine receptor to see whether it correlated with the response?
Oh, yes. The androgen receptor decreased by both the immunohistochemistry and the RPPA more in the lobular than the ductal. So we saw a decrease with treatment, and it was more profound in the combination group than the fulvestrant only. Yep.
Hi, that was really interesting. Suzanne Conson from UT Southwestern. One just comment first for Rita and the previous questioner about the two types of lobular breast cancer. You know, it's really interesting because it might be something to do with the degree of collagen production by the two different types of tumor cells. So it might be interesting to collaborate with our imagers and take a look at the type of collagen that's being deposited, because that may change the density and the visibility of the tumors. So that's one idea, because we're seeing two different types of collagen and two different types of lobular breast cancer. So that's one comment. My question is about going forward in terms of the neoadjuvant window trials. If the PEPI score doesn't seem to be as maybe predictive as we've seen in IDC, do you think there's another combination of things we should be looking at? And what role does the microenvironment have in terms of its changes when we're doing these neoadjuvant trials? That's for anybody.
I can answer. I mean, I think it's very challenging, neoadjuvant trials in ER-positive breast cancer in general, since we really don't have, you know, like HER2-positive or triple-negative, we don't have path CRs. And the Ki-67 is very limited in what you get from a Ki-67, although there is data to support the use of it. And PEPI score is good, but again, it's not a molecular test. So I think we need to think about better tools to really be able to use them as a predictive marker for later on outcomes and also for tailoring treatments, because right now we don't really have a good marker. I completely agree.
Suzanne, just to get to your question about the tumor microenvironment, we did see a significant change in a reduced number of Tregs and tumor-associated macrophages and the MDSCs in the combination with the fulvestrant plus enzalutamide compared to fulvestrant alone. So, and that was well, the TLSs were at time of surgery, but the others, it was going down even by week 5. So.
Yeah, that's interesting. And did you see increasing CD8 positive cells with the decreasing Tregs?
The CD8s didn't change. We are doing some in vitro assays with splenocytes, the mixed lymphocyte reaction assays, and looking at androgen agonists versus agonists plus antagonists and seeing if we see changes in like T-cell proliferation and you know, response, gamma interferon production. Yeah, more functional assays in vitro.
Okay, thanks.
Yes, Debbie. Hi, thank you. Very nice posters and discussion. My question is about the really nice international effort to collect pleomorphic LCIS and florid LCIS. Congratulations on that work. One of the challenges that we had in the past when I personally tried to do that was when people would send me their cases that their local pathologist called PLCS or florid LCS, when I would have my pathologist look at it, they would not agree that that was in fact the diagnosis. So did you have central pathology review of these cases, or how did you manage that?
Yeah, thank you very much for raising this point. That was an issue when designing the study, and we tried to sort this out by asking each center participating in the study to review all the slides according to the last pathology guidelines to confirm the diagnosis up to the recent guidelines.
Thank you. Other questions? I had a question for Dr. Moabi. Very exciting to see the very first therapeutic tool for risk stratification for early-stage invasive lobular cancers. How do you plan to think about next steps, or what is it that the next thing we should do now that you're thinking about this prognostic tool?
Yes, thank you for this question. So the first thing we're doing is externally validated. We found another database at Cleveland Clinic that does have the same factors that I have, so we're trying to validate it with them. Also, we did capture a lot of patients who received chemotherapy, so we are trying to see if it can predict chemotherapy benefit. And the last thing at ASCO, we're going to present how it compares to, I wanted to use the adjuvant online equation, but the one right now available is the CTS5, so we're comparing this tool to the CTS5. And it shows that, I mean, this tool is more specific to lobular, this way it's better, but these are the next steps.
Do you think at some point in the future we might be able to potentially generate a tool that might help with predictive benefit as well, given the challenges we face in lobular cancer specifically?
Yeah, that is the goal, and I'm also working with a company to look at RNA-seq data, if we can incorporate clinical pathological feature and RNA sequencing data together to try to risk stratify prognostic and predictive for chemotherapy benefit, and CDK4/6 as well. That's what we're trying to do.
Thank you for that great effort. Maybe one more question, unless there's something in the audience. I don't see anyone. So, you know, for our neoadjuvant efforts, congratulations on trying to accomplish that in PELEPS and also with the fulvestrant enzalutamide. I was just curious, now that you have these data with TBCRC037, with PELEPS, and with the enzalutamide study, how are you thinking about next steps based on what data we have? Is there plans to now take it to the next step? You learned something from here. This worked, this did not. We saw some signal. What is the next step that you plan to do with this?
From the perspective of the 037 study, it was a window of opportunity trial, so we have tissue before and after the administration of a short course of endocrine therapy. So really what we want to do now is take that tissue back to the lab and to try to find targets to try to fast track how we take care of patients with lobular cancer.
Thank you.
Yeah, I think a bigger study would obviously be better, and see if we can, you know, get more significance. We didn't quite reach the significance that we hoped, but maybe one more patient who had been on the combo arm and would have driven it to achieve our hoped for response. But so yeah, and then of course we can try other ER degraders and other anti-androgens or AR degraders, but hopefully we'll get to do another window of opportunity.
The intriguing signal in lobular was very interesting. So do you plan to expand that intervention specifically for lobular histology, you think?
You know, we'd probably take both IDC and ILC, but yes, it'd be great to enroll more lobular.
So we are actually in negotiations with various companies to try to land an AR inhibitor. It's difficult to persuade them that they want to invest in breast cancer. So that's the first issue. The second issue is the splenocyte and other studies to try to figure out which immunologic intervention would actually be the most productive. We suspect that this may be more related to TAMs, Tregs, and MDSCs rather than PD-L1, for example. So we need to work. So we're looking for combinations, first to confirm what we found, and second of all to, and we'll do 6 months instead of 4 months and so forth.
Thank you. Anything else to add from anybody from the panel? Renat, you wanted to add a comment?
I mean, I'm echoing my colleague here. We're also, you know, a lot of tissue was collected with this trial, which is a huge resource for us to study both the genetics as well as the tumor microenvironment. So we're working hard on trying to get this done. So there are great tools out there now, so we're very excited to work on this cohort. And if anybody's interested in collaborating, we're happy to collaborate also.
So in the interest of time, thank you all. Thank you all for all your presentations and all your hard work, to all your presenters and our two discussants, and thank you all for sticking around so late in the night today.